Well, welcome back, everybody. Thanks for coming to join us for another episode of our High Five web series where we're talking to experts in Washington, tackling some of the most important policy issues related to health information, health technology, and healthcare in general. It's been an active month in July, so we thought it'd never be a better time to bring together three wonderful experts from our Health IT End Users Alliance to talk about some of the different policy developments that we've seen both on the rulemaking side as well as some interesting White House announcements that have hit in the last couple weeks by the time you'll be hearing this next week. So without further ado, let's go ahead. I'll have our wonderful guests start to introduce themselves. So Daryl, if you'd be able to introduce yourself and your organization.
Sure, great. Thanks for having me. My name's Daryl Dredna. I'm the Senior Director of Regulatory Affairs at AMGA, and so we represent multi-specialty group practices and integrated systems of care. Been with AMGA coming up on 10 years, and appreciate you having me today.
Great. Mandy?
Hi, I'm Mandy Neff. I'm a senior regulatory and policy strategist at the American Academy of Family Physicians. The AAFP represents primary care doctors, specifically family physicians, and the organization is dedicated to enhancing the specialty of family medicine and ensuring our members have the resources and support they need to treat patients in every care setting across the U.S., from major hospital systems to one-room clinics. I'm part of the AAFP's government relations team, and I lead the organization's regulatory advocacy efforts on health IT, telehealth, and administrative burden reduction, as well as some of our workforce issues like student debt relief. Thanks to AHIMA for having us.
Thanks, Mandy. Mason?
Sure. Thanks for the invitation. So I'm Mason Ingram. I am Senior Director of Government Affairs at Premier. Premier is a technology-driven healthcare improvement company. It's how I would characterize the business that we do. We work with over 4,000 hospitals and health systems, a little over 200,000 other providers on delivering smarter, better, faster, high-quality healthcare.
Great. Well, hopefully everybody that's watching or listening at this point is familiar with the Health IT End Users Alliance. We're a collection of primarily provider-focused, but also technology and patient-focused organizations tackling questions as it relates to those who are actively using the technology in healthcare today, making sure that their voices are represented as that technology is developed and policy is made. So I guess to kind of kick us off, for those that are maybe looking for a little bit more of an introduction into the End Users Alliance. We've worked over the last several years. It's hard to believe it's been almost 3 years at this point that the Alliance has been working together, or at least starting to get these conversations off the ground. We're trying to increase that involvement in the development and policymaking process. But the question is, while we are trying to do that, why is that important? Why is it important to have the end user perspective early on? I'm not sure who wants to kick us off, or I'll be happy to volunteer someone as well if no one wants to start us off.
Uh, I can start us off if you want. I think trust is the word that comes to mind for me. It's like when you're rolling out this policy or this new requirement, are the folks who are actually going to be using it trust that it's going to work, trust that the folks that develop this policy understand what their day looks like, what their workflows look like, because it's one of those things where theory, hits practice, right? And is this new technology, is this policy really going to reflect what someone's day to day is? And I could spend 20 minutes talking about what that might look like in a multi-specialty group practice, but ultimately are the decision makers in DC, are the policy makers, is there a level of trust with the folks actually on the ground doing the work?
Mason?
Yeah, I would just add to that and say, technology is all for naught if no one uses it, right? It's
Yeah.
implementation 101. End users really know the real world challenges, what works, what's confusing, what gets abandoned. And if we want to build intuitive tools, we really need to know something about the intuition that we're centering in our design, right? And that includes designing public policy as well as technology. I like to say end users are truly living in the gaps that all of us are trying to fill with connection. So I appreciate, the End Users Alliance and look forward to our ongoing work.
Mandy, what's it mean for you to have end user involvement?
I think I agree with both of what Daryl and Mason said, of course. And the way I think about it is just that end users are generally solving for a different question than developers or policymakers are. Policymakers are often presented with an issue and are asked to develop appropriate guardrails or mitigate harm. Developers are very often asked what is the most efficient or fastest way to get something from point A to point B. And I don't think any of those things are wrong. I think all of those things are really important, particularly when patients' lives are on the line. But end users ask the bigger question of how does this contribute to the best possible outcome for patients, which goes back to the trust piece that Daryl was speaking to. End users are better positioned within the healthcare ecosystem to focus on that bigger picture and see how all of those disparate pieces of policy and technology fit together and what that net result and like offers to patients. So I think you can't really have the full conversation unless you have the folks who kind of sit at that higher level and are able to bring all of those pieces together.
You talked about being able to answer a question, and end users are looking at probably answering some different questions, maybe looking at different outcomes than some of the policy or technology developers are. We've seen, unfortunately, the Assistant Secretary of Technology Policy announce that there are some enforcement discretion as it relates to the real-world testing requirements within their certification program. And one area we as an alliance have really focused on is the importance of having end users in the real world testing program before technology is delivered and rolled out. What is the consequence of not having end users testing these products before we have them delivered? We've gotten some movement in a definition of what exactly does it mean to have a product delivered, but what are the long-term downstream consequences if this technology is not tested before implementation?
I think a lot about, some of the AI tools in the population health management and resource forecasting space. You can imagine, hopefully it's never happened before, but you can imagine a scenario in which, perhaps a tool is designed to project utilization of different healthcare services. And in the intended use case, you're doing maybe baseline resource planning. Now, if you take that tool and you use it for, say, prioritizing some kind of public health effort, you've probably made a significant mistake. You think about groups that underutilize healthcare services that they need to be utilizing, and you use the wrong tool or the right tool in the wrong way to identify these populations, and you've accidentally perpetuated access issues. So I think about this example a lot of why end user testing is so important, because you don't know what you don't know. And getting the right experts to use your tool or vet your policy ideas can really help mitigate what could otherwise be some pretty catastrophic risks.
Daryl?
Yeah, no, I'd agree with that. If the big picture, are we targeting the wrong population? And you drill down into the actual, clinical delivery system. Are we missing a handoff? There are documentation errors, so it just sort of spills over from, it sort of, to be a little crude, it sort of rolls downhill, right? If you're missing the big picture, and all of a sudden it gets worse when you're actually on the ground, and then from that, the folks on the ground, they're smart people. They're going to find a workaround, and all of a sudden they're going to keep trying to do the best they can. And all of a sudden you've got this tool that we've tried to develop that's being pushed to the side or not being used at all.
Mandy?
I think that the biggest consequence is just worse products. It's worse outcomes for both the end users and for the patients. Every health IT product is a component of a larger system that is clinical workflows and administrative workflows, and all of these pieces are built specifically to fit together and to work in a specific way. And so if you're introducing new products or technologies to those workflows without them having actually been tested before they go live, anything could happen. And thankfully, most of those like worst harms are avoided, mitigated. As Daryl said, smart people on the ground are doing what they can to work around it. But the most effective way to avoid those kinds of consequences is to have people's perspectives from day one. It's to guarantee that end users sit at the initial table when the ideas are being discussed. It is to make sure that they are involved at every stage of development and testing. And, I don't think anybody wants clinicians to have to be health IT experts, or for other members of medical groups to have to be IT experts. We hire those folks when we have the resources to, of course, but end users are the ones who are going to bear the brunt if those products don't work well, if they're not thoughtfully designed, if they haven't been appropriately tested, which is why it's so important for them to have the opportunity to participate from the beginning.
It's interesting you talk about clinicians don't have to be health IT experts, but we don't have that same conversation with using, I don't know, a phone. I don't think Apple or Google are designing a phone without having any discussion with those that are actually using it. And then it's a completely, new frontier for them. Like, I don't know, we'll see how people use it. Like they clearly do that testing beforehand, but we don't seem to do it in the health IT space and actively in policy and what we're trying to, prevent from happening. We're seeing play out in some of the electronic prior authorization conversations, right? With the development of these implementation guides to help roll it out. We're still having discussions for requirements that are coming soon because end users probably weren't at the table appropriately while we were designing that policy in the past. So I think all three of you hit on really what's important about trying to make sure that those using it can be able to help dictate the pathway in which it's moving forward. And I think looking at the next frontier of issues, and Mandy, I'm going to just let you know you're going to be first off the bat because Daryl and Mason have already gone first on these questions that I think real world testing is really going to come play an important part in is the continued use of artificial intelligence in healthcare. We know that AI is starting to be more widely used in a non-clinical and more apparent in a clinical space. But what does it mean to have AI in an end user space now? And what does it mean for healthcare if end users aren't a part of the active AI conversation?
Well, I think the biggest potential for AI right now in the healthcare space is to bring some of the joy that physicians and other healthcare workers talk about, like bring that back into this conversation. When I talk to AFP members and you hear, depending on the level of technology and AI integration, you hear different kinds of experiences, but you still have folks who are spending a quarter of their day on prior authorizations or on fighting the different portals or on chart cleanup. And then you have folks who their systems were early adopters of AI. And so they have their ambient scribes and they have somebody like doing the first round of the prior auth triage. And to see these technologies really be put into place and the difference it can make in the joy that it returns to those who are delivering medicine to their patients and the increased time they can spend looking their patients in the eye instead of staring at a screen. When AI is thoughtfully developed and implemented, to me, that's the biggest difference. That's the potential for the healthcare system is for, we have all these physicians retiring. It's harder and harder to convince new people to go into medicine, particularly into primary care, I'll say. And so to see it done right, means there's huge potential to motivate folks to want to go back into that space. And this is, again, if you have end users involved at the beginning, then you're more likely to get those products right. And you're more likely to be able to bring that joy and that just fulfillment of really getting to deliver patient care back into the healthcare system, which I think is desperately needed.
I've talked a lot about AI, Mandy, and you've never mentioned the joy. That's such an interesting perspective on what AI can add to healthcare. Daryl, what about you from your perspective?
Yeah, no, I would agree with that entirely, and it's important. Like everyone's really excited about AI. We're using this more and more in our daily lives, and especially in healthcare. But we got to make sure we're asking the question like, how are we going to use this tool to Mandy's point, help our clinicians deliver care that's not just as add on. We want to make sure the tool is working for us and we're not working for the tool. And I think there's a lot of that in health IT that we've got to check this box and do this. And if we can switch that, so, hey, this is helping me schedule better. This is helping me refer better. This is giving me time back in my day. So maybe I can spend a little bit more extra time with a patient or I can take on an extra patient. I think that's the potential. I think that's what everyone's really excited about. How we get from where we are now to there, I think that's going to be the challenge. I'm optimistic we'll get there, provided we get those clinicians who are doing the work as part of this conversation early on.
Mason?
Yeah, well, I hope that AI continues to be a workforce extender, right? Healthcare labor shortages are so severe. We can use all the help we can get. And I think what we're starting to see is providers really leveraging the tools to, just to put an exclamation mark on, Mandy's point, it's really starting to reawaken that provider-patient relationship. To be able to look up from note taking on a laptop during a visit because you have an AI ambient note taker, to do more outreach and to do more follow-up to a larger patient panel, to catch, and prevent potential harms. I have personally heard more than one provider say that these tools are helping remind them why they practice medicine, and that's to improve the lives of patients. I think, one other thing I was thinking about is the potential to unlock maybe a lot more patient-generated data as well. Both, patients being more willing to talk in a visit, have a more free-flowing conversation to, maybe spell out that data point that helps uncover a symptom or helps to catch a disease earlier or helps to implement better prevention, as well as, a lot of new data coming in from devices in new and interesting ways that providers are having to start to interact with and apply some of their clinical expertise to ensure that the right data makes it into the medical record. So I hope that we see AI continue to be helpful, and I hope that it helps providers continue to keep the patient at the center.
Shifting gears a little bit out of, some of the things that we've been focused on as an alliance to some of the more breaking, well, I guess as breaking as almost 2 weeks old can be at this point for health technology. Some of the more relevant news that is coming out. Mason, you talked about patient-generated data, and we've talked a lot about AI just now in this conversation. Those were two big fixture points at the White House event at the end of July. It's tough to believe that was already last month that event took place. But at it, the White House did announce a new CMS initiative focused on, network data exchange, right? CMS aligned networks was the phrase that they've been using along with the idea of killing the clipboard and enabling AI. We've seen a lot of talk on LinkedIn from some of the, LinkedIn health IT influencers on what their takeaways have been and those that were at the event itself. But, for each of you and your organizations, what was the most important takeaway from that event other than, boy, it's been a long time since we've had a president talk about health IT on a very public stage. But for each of you, I don't know which of you would like to start first, but, what was your big takeaway? I will call on one of you. Mason, if you want to go.
Yeah, I think, I think it's pretty clear that this administration is trying to look at all of the different nodes of the healthcare ecosystem and think about how they fit together. So it's no longer just, provider, patient, payer, EHR. It's not even just QHINs. If you look at the list of the early signatories, it's really interesting the types of organizations that CMS thinks fit under this sort of like CMS networks umbrella. There are a lot of organizations that are collecting and handling and analyzing data that don't really fit into traditional boxes from a policymaking perspective. And so I think one of the key takeaways for me was, in addition to sort of the primacy of the patient and patient access to data and patient-facing APIs, this sense of what are all the pieces of the health tech ecosystem? How do they fit together, and how do they share data?
I would just say that I think what I found most interesting about the White House event is just this continuation of the shift in process that the administration is taking. It's pretty clear through, the prior authorization announcement we saw a few weeks ago, and then through this interoperability pledge and framework that we saw at the end of July, that the administration, the HHS, but the administration more broadly, really wants to emphasize private partnerships, moving away from the traditional regulatory process. And so the most interesting piece of that for me is who is and isn't, to Mason's point, included in that initial set, who's being prioritized for participation, I guess might be the way to say it. And quite frankly, the lack of physician involvement is quite interesting and quite concerning to me and for the AAFP. When you go to CMS's new website where they list the early adopters and they have the section on health systems and providers, it's not a very long list, first of all, but also some of those folks, patient care is not their primary revenue stream or what the company does first and foremost. And that's not necessarily bad. Everybody there provides patient care in some way. I'm not calling anybody out, but it's interesting to see who got prioritized on that list and who wasn't at the table. And so I guess I think you can learn a lot from who gets prioritized and who's invited to be in a room for big announcements like this. And so I found that aspect of it really interesting in seeing, I mean, we know we need physician buy-in, we know we need medical staff support buy-in to make these things happen because they're the ones who are going to have to be doing it on the ground. And so as the rubber meets the road in the coming year, where do physicians get prioritized? Where do they really get brought into the process? What does that look like? That was really my biggest takeaway and what I'll be looking for.
Yes, I think Mandy just stole my point with looking at the list, but we come for similar, similar spaces here. Like, um, taking it a step further, like, okay, we're going to have this interoperability, we're going to have this data sharing, and thinking down the road, at least going out of the health IT world a little bit, like, what does this mean for value-based care? How are they going to use this to shift it over into the reimbursement world, and what does that look like? So that's what I'm sort of focused on for next steps for this, which I know isn't the exact question you asked, but that's what that was my takeaway anyway.
No, I mean, it is interesting to see. I mean, a lot of my questions have been around, what does it mean for CMS to take the lead on some of these conversations that ASDP ONC have traditionally led. And uh, Mandy, I think Stat did some follow-on reporting to what you're talking about on who's signed on onto which individual pieces of which um, portions of the pledge on, what companies, what does it mean for some of the companies to be signed on as a provider or an A? And it sounds like some of them are also figuring that out themselves as well. And Mason, you mentioned the Qualified Health Information Networks, QHINs, the Trusted Exchange Framework and Common Agreement is clearly the one of the major questions that many of us still have is they're still exchanging data, they're still active, where I think we're all still supporters of what they're doing and what does that mean for CMS? So yeah, I think all of you hit quite well on what those questions are. And Daryl, to go back to your final point too, was looking at, there's been lots of conversation on MA value-based, how exactly CMS is going to look at paying for care. And that can bring us right into our final question. The July event was clearly the first steps for the administration. There was already a rule that came out the next day or 2 days later, I think, further expanding the work that ASDP is doing on electronic prior authorization. There's more reporting coming out there finding that ASTP is maybe signaled that they're moving more towards API certification moving forward and maybe away from EHR certification, although they haven't said anything formal on that at this point yet. But for each of you, and we'll go, Daryl, Mandy, Mason on this, what exactly are you expecting over the next year? What do you expect to see out of the health IT policy environment?
Oh, it's like drinking from a fire hose, I think. It's a really exciting time. And so you're going to have this increased emphasis on data sharing. They want to speed prior authorization clearly, right? So how that shakes out, I think you're going to have this ongoing, I'll say conflict, but there's this pain point and I'm speaking direct just about the prior auth. I think that's going to come to a head at some point. What can't go on forever won't, right? So that I hear more and more from my membership about what a burden prior auth is. So I think that's the first piece they're going to try to address through their health IT work. Like that's sort of going to be the case study or example that they want to put a win on the board. And I think that's and I think improving that process is going to be what they're going to put their emphasis on over the next couple months and years. And that's going to spill over, I think, into like the reimbursement realm, which CMS has taken this on. So I think I've always got like they're a payer first. So I think that's always going to be their mentality here. So I think I'm rambling a little bit, so I'll stop there.
Oh, it's great.
Yeah.
Mandy?
Yeah, at a high level, I think I'm most expecting to see, at least on the regulatory side, a continuation of what they've been forecasting and starting to do. I think we will continue to see more private industry pledges, voluntary frameworks. I think we will continue to see less of an emphasis on the traditional regulatory process. And I think that to kind of mirror that on the legislative side, which I know isn't exactly what you asked about, but I think it's really relevant here, that we probably all expect congressional inaction to continue on both data privacy and AI governance. And for as long as that continues to be true, we will see the states take action, which is only going to make this more and more complicated for folks on the ground. And so I think we will continue to see the continuation of all of those things that we have been seeing. But then as this framework proceeds specifically, I will be looking at what HHS does, what actions they take, and how you protect patient data that is outside of HIPAA. This is Andrew, you and I have talked a lot about this. This nation is desperately overdue for a health data privacy framework, for an actual law that governs health data that is outside of HIPAA. I really struggle to see how you make meaningful progress on really exciting and ambitious frameworks like this when you don't have those kinds of protections in place. And so I will be really curious for how HHS tries to go about that, with the understanding that Congress is probably not going to take action in the next few years at least.
Mason?
Yeah, well, I think we're going to see, interoperability re-envisioned. I do. We have a public policy perspective, this sort of long history of looking at data blocking, attempting to define it, or I guess say what it's not from an exceptions-based framework. We've had pushes and pulls from ONC health IT certification requirements. I think we're really starting to see a movement that's closer to being in lockstep across policymakers. And I think that holds a lot of promise. From interoperability flows, potentially, hopefully, real-time data exchange. To Daryl's earlier point, I spend a huge amount of time in my day job talking with providers and provider organizations about the lag times in prior auth and the administrative cost of just the really manual processes that are involved in the business of healthcare. And as we really barrel forward towards real-time prior auth in particular, it's just so important to do it in a way that works for end users. We're all building this plane as we're flying it, but it can't be a quick and dirty attempt to just get something done. To be durable, it really has to work on the ground. It has to work in the hands of providers. So that's actually my, number one advocacy priority over the next couple of months, unless, something new comes along and surprises me. To Mandy's point, that has happened a few times under this administration.
No, that's great. I just want to get further clarity. Are we going with ONC? Are we going with ASTP? Are we going ASTP ONC? It seems to change based off the meeting we're in. No, all of those points are very important. I think all of you hit on a number of the questions that both came out of last week's event, as well as some of the broader questions that the new political appointees have been asked, right? All of the areas you've talked about, CMS, OCR, and ASTP ONC at this point have political leadership in place. So it'll be interesting to see how that shapes or reshapes the work that they're going to do. This has been such a great conversation. I really do want to thank Daryl, Mandy, and Mason from their organizations, as well as on behalf of AHIMA, for taking time today to talk with us about some of these important issues. Please make sure that you find them all on LinkedIn, as they're all such great knowledge bases for some of these important issues. And make sure that you subscribe to us and get the next episode of the High Five that'll be coming up in October. Well, no, it's only August now, so it'll be in September. Thank you all, and we'll talk to you next time.